Welcome to this podcast on physiological concepts of cardiac and autonomic nervous system for first-month residents. I know that you are aware that blood pressure is a product of cardiac output and stroke and systemic vascular resistance, and that cardiac output is calculated by multiplying stroke volume and heart rate. Let's expand upon that. The ABA content outline is shown on this slide and will help in your self-study of these topics. The educational objectives of this podcast are shown in this slide, and it is to review the basic cardiac physiology, cardiac output, systemic vascular resistance, and to review cardiac autonomic physiology, parasympathetic versus sympathetic nervous systems. How does general anesthesia affect autonomic nervous system function, and to recognize that there is a cardiac and vascular interaction. So first, cardiac output is equal to stroke volume times heart rate. 75 mils times 80 beats per minute gives you 6 liters per minute. Here's a quick little question which was designed for audience response. And given a patient on a milrinone infusion with an MRI study showing that the end diastolic left ventricular volume is 300 mils and the end systolic left ventricular volume is 225 mils. The blood pressure is 100/70 and the heart rate is 80 beats per minute. What is his ejection fraction? In fact, this is determined by subtracting his two volumes and arriving at a stroke volume of 75 mils over the end diastolic volume of 300 mils, giving an ejection fraction of 25%. The blood pressure has nothing to do with it. And historically, what we studied when I was a medical student involved venous pressure curves that look something like this. Now these days pressure volume loops are used. Looking like this. And like this. This figure adds the concept of stroke work, which is the area within that curve bounded by A, B, C, and D. This is a ventricular pressure volume loop which shows the concept of increased afterload, and you can see that in the purple outline with the higher intraventricular pressure representing higher aortic pressure and afterload. And this slide showing the effects of systolic and diastolic dysfunction. Note the steep rise in filling pressure in the pressure volume loops on the right without enlargement of the ventricle, representing a stiff ventricle. This figure comes directly from Kaplan's cardiac anesthesia of the echo era. And And this textbook is an excellent resource for physiology. I also suggest that if you want to acquire a strong grasp of preload, afterload, contractility, and arterial elastance, you should view these video tutorials from the Khan Academy. So, time for another question. Classically, cardiac pump performance is not determined by A. Preload, B. Contractility, C. Inotropic state, D. Lusotropic state, or E. Afterload. The classically cardiac output is determined by preload, afterload, contractility, and heart rate, not lusotropy, which is defined as the rate of myocardial relaxation. The best definition for preload is A. Right atrial pressure, B. The quantity of blood in the chamber before contraction begins, C. The left atrial pressure, D. The left atrial volume, or E. A normal ejection fraction. Experimental and clinical estimates and correlates of preload are shown on this slide, and the best answer for left ventricular preload is left ventricular end diastolic volume. So in that question, the quantity of blood in the chamber before contraction begins is probably the closest to the correct answer. It is a bit of a tricky question. This slide provides you the answer. Now another question: which agent affects preload? Propofol 1%, isoflurane 1%, nitroglycerin 200 micrograms per mil, epidural bupivacaine, or E, all of the above? And the answer is all of the above, and it is because of venodilation. When you have venodilation, you develop pooling of blood and a decreased volume as preload. This pressure volume loop shows decreased preload in red, and I believe you can see that a smaller stroke volume results. It's quite easy to imagine how propofol could cause a preload decrease and an afterload decrease and shift the pressure volume loop down and to the left, causing hypotension. This pressure volume loop shows a fixed afterload and inotropic state and a decrease in preload, such as might occur after hemorrhage or dehydration. As the text indicates, the pressure volume loop, which is smaller, shows a lower stroke volume from a lower preload. And while the pressure volume loop shows a reduction in stroke volume, there is no decrease in blood pressure in this graphic, which is not quite typical of anesthesia. This pressure volume loop could represent dehydration or perhaps even a blood donation with some compensation. Now another question. Afterload is best defined as A. Increased mean arterial pressure, B. The additional thickness of the left ventricle, hypertrophy, C. The additional load on the cardiac muscle fiber after contraction begins, D. The additional work on the cardiac muscle fiber after contraction begins, or E. A 50% increase in stroke volumes. And the answer is the additional load on the cardiac muscle fiber after contraction begins, which, if you are a strict physiologist, should be quite easy for you to understand, having done experiments. Another question. The most commonly used clinical measure of afterload in anesthesiology is A. Mean arterial pressure, B. Systemic vascular resistance, C. End systolic pressure, D. Aortic impedance, or E. Wind-Kessel parameter. Simply put, the most commonly used clinical measure of afterload in anesthesiology is systemic vascular resistance. Here's another question. Systemic vascular resistance is calculated using which three variables? Cardiac index, mean arterial pressure, CVP, B. Cardiac output, mean pulmonary artery pressure, wedge pressure, C. Stroke volume, mean arterial pressure, CVP, D. Cardiac output, mean arterial pressure, CVP, or finally E. Systolic blood pressure, diastolic blood pressure, and pulse pressure. This is the formula to calculate systemic vascular resistance and has three variables: mean arterial pressure, right atrial pressure, and cardiac output. Most physiological monitors have this formula built in and is available for clinical use. However, you do need to have a measure of cardiac output. So let's agree that afterload is a very complex subject which uses terms like aortic impedance, viscoelastic forces, frequency dependence, Fourier analysis, and wave reflection. Really quite complex. And now we may be getting in over our heads. But we do need to consider how the ventricle interacts with the vascular tree. So, this was supposed to be a group audience response question. I studied ventriculo-arterial coupling in medical school. I can tell you that I didn't. And with regards to left ventricular arterial coupling, this question is meant to see how much you know about this topic by A. is not affected by desflurane, B. is defined by the ratio of end systolic elastance to arterial elastance, C. exists only in dogs, and D. is not affected by isoflurane. So the obvious answer is defined by the ratio of end systolic elastance to arterial elastance, because most of the other choices are almost nonsensical or attempt to be distractors. And what is the ratio of end systolic pressure, volume, and end systolic pressure stroke relations and arterial elastance? Well, this figure from Kaplan's cardiac anesthesia attempts to depict the end systolic pressure volume relationship, ESPVR, and the effective arterial elastance. And hopefully this introduction to advanced ventricular arterial coupling will have some practical use in your self-study. This slide here shows a group of pressure volume loops along the end systolic elastance or contractility line and the end diastolic compliance line, showing that as left ventricular volume decreases, so does the left ventricular pressure, of course, but all along a line of which has the same slope, representing contractility. So is left ventricular arterial coupling important? Well, it is important enough to be included in anesthesia textbooks, and as you can tell from this paragraph, the stroke volume from the left ventricle to the arterial circulation requires appropriate matching of these mechanical systems. And the way that these are depicted involve elastance of the contracting left ventricle and the arterial vasculature, and these are determined from pressure stroke volume relationships, such as shown on these slides that we've been reviewing. And these same concepts are included in research in human septic shock, as depicted in this article from 2014. So from a research point of view, at least, these parameters are being studied. And what about anesthesia agents? Ventricular arterial coupling and mechanical efficiency with remifentanil in patients with coronary artery disease has been studied. And this is the conclusion from that article, and not surprisingly, an effect of remifentanil on contractility and left ventricular afterload can be measured. And shows that remifentanil, although an opioid, does have an effect on left ventricular arterial matching. From the point of view that the left ventricular volume is increased and the stroke volume is not increased. In fact, it may be slightly decreased. The fact that the diastolic pressure is not elevated is somewhat out of keeping with a heart failure picture to an extent. However, it is not uncommon to find that a compensated and treated patient with dilated cardiomyopathy does not have an elevated end diastolic pressure. As this slide attempts to show. Diastolic dysfunction resulting from impaired distensibility manifests in a pressure volume plane as an increase in the slope or leftward shift of the end systolic pressure volume relationship. The ventricle requires a higher filling pressure to distend sufficiently to receive an adequate end diastolic volume, which, if you remember, is the determinant of a stroke volume. Other textbooks also provide a different view to physiology, and this is a textbook which I picked up and which I recommend in your self-study. This slide is meant to depict differences between systolic and diastolic dysfunction in heart failure. You can see from the pair of pressure volume loops on the left that with systolic dysfunction there is an increase in volume of the heart with a reduction in stroke volume. And with diastolic dysfunction, the heart is not enlarged, but it does have higher filling pressures. Here's another multiple choice question. Choose the incorrect statement regarding diastolic heart function and or dysfunction. A, predictor of early mortality. B, primary symptom is dyspnea. C, volatile agents worsen diastolic function. D, EA ratio is always abnormal. Or E, diastolic heart failure is now termed heart failure with a normal ejection fraction. The correct answer is that the EA ratio is not always abnormal. This is a very complex issue which I will attempt to introduce you to by reviewing cardiac cycles in the next few slides and some echocardiographic information which hopefully will help you understand diastolic dysfunction a little bit better. In the world of cardiology, diastolic dysfunction is associated with early mortality. The primary symptom is dyspnea. Volatile agents tend to worsen diastolic dysfunction or at the cellular level. So this is a famous cardiac cycle slide. And the various curves show the pressures and in the various parts of the heart. And during cycles which are labeled 1, isovolumic relaxation, 2, rapid ventricular filling, 3, reduced ventricular filling, diastasis, and 4, atrial systole. So you can see that during atrial systole the mitral valve closes, and which is a result of the pressure in the left ventricle exceeding that in the left atrium at the end of atrial systole. This slide attempts to depict simultaneous relationships between the left atrium and the left ventricular pressures and filling rates. And this all is linked to echocardiography these days with the measurement of the velocity of mitral inflow and the annular or tissue Doppler measurements. All quite complex, and maybe certainly not a introductory level topic. However, one thing that you should realize is that as diastolic function deteriorates or heart failure begins to be manifest, there is a pseudonormal pattern which makes it difficult to use echocardiography as the sole determinant of diastolic dysfunction, although there are many works in progress and some guidelines which help cardiologists determine which patients have diastolic dysfunction. This slide reiterates the fact that it has been long recognized that one of the first indicators of diastolic dysfunction is an increase in the A-wave velocity, and then as it continues to progress, there is pseudonormalization. So at the end of this first session, I encourage you to try to understand basic concepts first, like what is stroke volume and what is cardiac output. Ultimately, you'll have to learn how to measure cardiac output, how it is measured in the cardiac cath lab, how it's measured in the intensive care unit, how it's measured in the operating room. And beyond that, you will gradually learn and understand the effects of systemic vascular resistance and the coupling of the ventricle to the arterial afterload and the arterial elastance. All of these things have the potential to have an effect on patient response, sometimes unpredictably. So, in conclusion, at this point in time, after about 29 minutes, I thank you for your attention and hope that this introductory podcast will have some benefit in helping you understand the level of knowledge that you're ultimately going to have to acquire. And I invite you to listen to the second podcast, which will be on the autonomic nervous system as it relates to cardiac physiology.